Good afternoon. Good afternoon all, and thank you for giving us the chance to have this presentation. My name is Samer Karim. I'm the medical advisor for the cardiometabolic at Novartis. Unfortunately, Dr. Ferial was unable to attend this meeting, and I will replace her for this presentation. Actually, the presentation title will be Vildagliptin Efficacy in combination with metformin for early treatment in type 2 diabetes mellitus. Starting with a quick introduction and background. As you can see here, we are having a case which is a newly diagnosed diabetic patient with the following details. This patient has an age of 39 years old. His sex is male. No history of comorbidities, and at the same time, the A1C is 7.8%. Eventually, we are treating this patient with metformin and lifestyle medication. But the question is, if the patient is controlled for more than 3 months and his A1C is below 7%, shall we escalate his treatment or not? This is the question. Now, according to the recent guidelines which has been issued in 2020, we can see clearly that the first line therapy is metformin with a comprehensive lifestyle dietary, including weight management and also physical activities. The combination therapy is also very important. Why? Because from a pharmacological point of view, we can tackle different and multiple channels, including pathophysiology, including also pathogenic abnormalities, and at the same time, it's very important from a pharmacological point of view because we need to prevent and slow the decline of beta cells function, and we need to preserve beta cells function as well. So, while there is some support for initial combination at the time being, unfortunately, we are not having the data. We are not having a clear and relevant data which will support us to provide the patient with an evidence that a combination therapy is better than a sequential monotherapy. From here, we start thinking about a study which will prove that the combination therapy is better than initial sequential monotherapy. And the VERIFY trial was definitely a different clinical trial than the trials which are recently conducted and which are answering different or a separate question than the VERIFY trial. Majority of the clinical trial which has been conducted in the recent time were answering the question of the cardiovascular outcome. However, the VERIFY trial was assessing the role of a combination therapy compared to a sequential monotherapy. And we can see here very clearly that the baseline of A1C was between 6.5 and 7.5, which is really very low baseline, and including patients who were early diagnosed, which is different from the cardiovascular outcome trials which has been conducted in the past time. So this is a totally different question, and we need to prove that the combination therapy is better than a sequential monotherapy. So this is the study design. You can see that VERIFY was a randomized, double-blind, two-arm parallel group study consisting of screening visit of 3 weeks in period with a primary defined failure threshold. What is the failure threshold? The failure is considered when the patient is having an A1C above 7%, okay, for 2 consecutive visits, and the visit is considered every 3 months, okay? It was conducted over 5 years treatment period with patients. Treatment is consecutively intensified in if clinically indicated. So here you can see that the VERIFY trial was a multi-center and multi-ethnic study, and this is very important for any clinical trial because it was recruiting around 2,000 patients from 34 countries, 254 centers, so different ethnicity, and here we can prove that the combination therapy is effective across different ethnicity and different population. Regarding the study design, one point very important about the drug-naive patient, you can see that those patients were having metformin maximum for 4 weeks, At the same time, the A1C was varying between 6.5 and 7.5%. So this means that those patients were early diagnosed and the A1C was really very low. At the same time, we can see that those patients are having diabetes with less than 24 months or 2 years. Regarding the baseline characteristics, you can see that there was a clear relevance between the early combination and the initial monotherapy. There was the baseline characteristics were comparable between both treatment groups, and there was no deviation as well. And regarding the gender, regarding the age, regarding the A1C, we can see here that it was comparable between both treatment groups. The most important here, you can see that the A1C was 6.7% in terms of average, and this is similar to the case which we presented in the beginning of our presentation. So we will see here if those patients with 6.7% as A1C will benefit from a combination therapy rather than a sequential monotherapy. This is the study design. As you can see, after having a running phase for 3 weeks, the patients were escalated from metformin 500 milligram to metformin 1,500 milligram. And then those patients were randomized into 2 arms. The first arm on combination therapy, including metformin plus vildagliptin 50 milligram twice daily, and metformin plus placebo, also in 1 arm, until the time to first failure. The time to first failure is considered whenever the patient is having an A1C above 7% for 2 consecutive visits. And this means that the patient will have the first failure at least in the first 6 months. The period 2 starts after having the patient failed in the period 1, and we can say here that the patients were switched from a metformin arm to metformin plus vildagliptin. So the patient will continue on a combination therapy compared to the first arm, which is initially with a combination therapy. The third period, when the patients start to be eligible to insulin, and here you can see that the phase 3 starts whenever the patient failed the period 2. What does it mean the patient failed the period 2? Again, the patient is having an A1C above 7% for 2 consecutive visits. Moving forward right now to the results. So the primary analysis was the time to confirmed initial treatment failure, okay, as assessed by having a patient having A1C above 7% for 2 consecutive visits. The secondary analysis, including the progression of A1C after the start of period 2 to the end of period 2, assessed by second treatment failure or by slope of glycemia. We need also to confirm the safety profile of the combination therapy. And at the same time, we need to assess the adjudicated cardiovascular events. And this was an exploratory endpoint because this clinical trial was not powered to detect the cardiovascular outcome. This is the result. The primary endpoint was significantly met. We can see here the p-value was significant. And the early combination treatment almost halved the risk of time to initial treatment failure versus monotherapy. So right now, we are having an evidence that the combination therapy will reduce the time to first failure compared to the monotherapy strategy. Again, this is also a very important slide. We can see clearly that the patient will have 2 extra years of glycemic control with the early combination strategy. And you can see here that with a combination strategy, the patient will gain 2 more years of glycemic control compared with a sequential monotherapy. Moving forward, what about right now the time to second failure? The time to second failure was reduced also significantly by 26%. We are talking about the time of second failure whenever the patient is having an A1C above 7% for also 2 consecutive visits. So also the time of second failure was confirmed and it was reduced by 26%. If we will also check the success rates between treatment approach, we can see here also clearly that the proportion of patients having A1C below 7% was significantly lower with the early combination compared to initial monotherapy. If we will check also the proportion of patients having an A1C below 6.5%, we can see also clearly that there was a significant reduction with the combination therapy compared to a sequential monotherapy. And we can see also that 3 out of 4 patients on early combination achieved an A1C below 6.5% at 3 months. And this was kept until the 5 years of duration of this clinical trial. What about the subgroups? We saw in the beginning of this clinical trial that we had some subgroups including the A1C, including the body mass index, and including the gender as well. And we can see also that according to different subgroups, the combination therapy provide better outcome compared to a sequential monotherapy. And we can see here clearly that the confidence interval were favoring the combination therapy compared to the sequential monotherapy. This was irrespective of the race, of the geographical region as well. And as we can see here that the p-value of heterogeneity was not significant, and this means that there was no deviation between treatment groups. Finally, what about the adjudicated cardiovascular events? This is very important to say here that this clinical trial was not powered to detect the cardiovascular outcome, because the initial question was to compare the combination therapy with a sequential monotherapy. Right now, we can see clearly that the time to first adjudicate macrovascular event was significantly lower with a combination therapy compared to a sequential monotherapy. However, this was only numerical. We can see that we had around 30 cases with the combination therapy compared to 44 cases with the initial monotherapy. And the p-value was not significant. However, this clinical trial can be a good indicator that if we will conduct such type of clinical trial, assessing the role of early combination will provide on the long term better outcome in terms of adjudicated macrovascular events. Finally, what about the safety profile? The safety profile was consistent, and we can see here that the case of hypoglycemic event were comparable between treatment groups. There was no deviation between both arms, and here we can confirm that the early combination will have the same safety profile as a sequential monotherapy. So in summary, what we can say? In summary, and based on the outcome of the verified clinical trial, there was a clear change in the ADA and the ESD reports, and we can see clearly that the combination therapy has a clear role in the management of heart failure of the patient with diabetes. And accordingly, we can see that using a DPP-4, especially the Vildagliptin, will provide the patient with metformin with better outcome than a sequential monotherapy. So in conclusion, we can say that the early combination treatment will halve the risk of time to initial treatment. At the same time, the median time of failure was 3 years in the initial monotherapy strategy compared to 5 years in the early combination strategy. When we are talking about the time to second failure, the risk of time to second treatment failure was reduced also by 26%. And finally, both approaches were safe and tolerable. So we can say here that the early combination compared to sequential monotherapy was proven. And this is the outcome of the verified trial. Thank you so much.